myself Dr. Priyanka, and I'm one of your mentors for Study EFOG. So today we are back with the RRR YouTube series where we will be discussing important single-based answers and also the extended matching questions for the Pediatric Gynecology module today. So do like, share and subscribe StudyMEDIC channel and also press the bell button icon to get the updates on the recently added videos. So always remember that success is not final and failure is not fatal, and it is the courage to continue that counts. So now coming first, we will be discussing 10 single best answers, and followed by that we'll be discussing 10 extended matching questions. Now coming to first question for the pediatric gynecology module. So she is a 6-year-old girl who comes with her mother because she has been bleeding vaginally for the last week. Okay, so she is a 6-year-old girl. Okay, and she has been bleeding for the last week. So what is the most common cause for her? Okay, for a 6-year-old girl to have bleeding vaginally. So we can see from the options down that all are the causes that can cause bleeding vaginally. The foreign body, precocious puberty, or a sexual abuse case, or a urethra prolapse, or a vulvovaginitis case, all can cause bleeding vaginally. But what is the most common cause of this complaint is the vulvovaginitis, that is the infection. So it is generally the most common cause of gynecological problem in prepubertal girls. So what can be the causes of vulvovaginitis? It can be infection due to yeast, bacteria, or viruses, or it can be due to some allergens or detergents or soaps or perfumes also that can cause itching or vaginal bleeding. And sometimes other causes are, we shouldn't forget, that is foreign body or a sexual abuse, which is not though common but can cause vaginal bleeding. And also in prepubertal girls, like postmenopausal women, same in prepubertal girls, the estrogen levels are very low. Okay, so which cause the thinning and dryness of the vulva and vaginal skin, and hence it can lead to intense itching, and hence this itching can cause bleeding. Okay, so these are the different causes of vulvovaginitis, which is the common cause for bleeding in prepubertal girls. Now she is a 15-year-old girl who presents with crampy lower abdominal pain, which radiates to her legs. Okay. And for the past year, the pain has coincided within the first 3 days of her menses. So she is not sexually active. Her history and general examination are unremarkable. Okay, so she is not sexually active. Otherwise, her history examination are normal, and she has crampy pain in the first day of menses and lower abdominal pain. So which suggests of dysmenorrhea. Okay, which is commonly seen in a 15-year-old girl. So what is the optimum management for these cases is by giving the NSAIDs, that is the non-steroidal anti-inflammatory drugs. Okay, so because these are the most commonly drugs which are given for the pain in case of dysmenorrhea. Okay, and also mefenamic acid also is given, but there are studies which show that if it is given in that is, if there is overdose, then it can also it can induce seizures. Now there is a 12-year-old girl who presents to accident and emergency with lower abdominal pain. On examination, there is large pelvic abdominal mass, and transabdominal ultrasound scan shows bilateral solid ovarian tumors. So ovarian tumors, the causes can be different according to the age group. So in case of young age, okay, so it can be, the causes are different. In case of middle age, it is a borderline ovarian tumor, and in case of elderly, it's a epithelial ovarian cancer. So in case of younger people, in a young girl, the most common causes can be a mature cystic teratoma. Okay, that is a dermoid. So they are typically found in 15% of all ovarian neoplasms, and mostly seen in young women around the age of 20 to 30 years. And uh, they are also prone to predisposed to torsion, okay, the teratomas, and they can be present with acute pelvic pain. And 15 to 20% of them are almost bilateral. So these should be remembered. So there can be various contents in a dermoid cyst. There can be hairs, eyes, thyroid tissue. So all this, and the mature cystic teratoma is commonly seen in young girls. So there is a 15-year-old girl who attended with her mother, and she wants to know about HPV vaccine. So during the school time, she has missed the HPV vaccine during the immunization program. Now she's 15 years old and she wants to have the HPV vaccine. So what can we do? How can we give her the HPV vaccine? So the recommendation is, if the girl is 15 years or more, we need to give three instead of two doses. Okay, so we need to give three doses. When can we give? So 0 month, that is now, and then 1 month after the first dose, and then the third dose will be 6 months after from the first dose. Okay, so the answer here is D. That is the first girls who have not received HPV vaccine and they are 15 or more years old, so they can be given three doses instead of two, 0, 1, and 6 months, and who are less than 15 years, so they can be given two doses. Now there is a 15-year-old girl who presents to accident and emergency with pelvic pain and vaginal discharge. Okay. And on examination, she is found to have pyrexia, that is fever of 38 degrees. So there is signs of infections pointing towards signs of infections, and there is moderate lower abdominal tenderness. And vaginal examination confirms bilateral adnexal tenderness and cervical motion tenderness. So this all clinical pictures points towards the pelvic inflammatory disease. So which of the below clinical features are not suggestive of PID? So in PID, we can see lower abdominal pain, which is typically bilateral. There is deep dyspareunia. There is associated abnormal vaginal bleeding. It can be a postcoital intermenstrual bleeding or an excessive heavy menstrual bleeding, or there can be an abnormal vaginal or cervical discharge, which is often purulent because it is mostly due to an infection. The answer here is answer E, where there is typically unilateral. So in PID, the pain is typically bilateral, okay, not unilateral. So a diagnosis of PID, it can be suspected, especially in high-risk groups. Who are the high-risk? Who are under 25 years of age and sexually active women. And if there is a change in the partner in the previous 12 months, and they can present with lower abdominal pain, which is typically bilateral, vaginal discharge, and bleeding disorders like intermenstrual or a postcoital bleeding, or there can be heavy menstrual bleeding. Now, there is a 12-year-old girl who was brought to the hospital with severe lower abdominal pain and was diagnosed to have hematometrocolpus. Okay. And after examination and investigations. So, surgical management with hymenectomy and drainage was recommended. And initially, the girl refused to undergo the procedure, but later she agreed after her mother and stepfather calmed her down. So, which of the following options it is most appropriate for you to obtain the consent in this girl? So she's 12 years. She is with her mother and a stepfather. Initially, she refused to undergo the procedure, but now she has agreed. So from whom are you going to take the consent in this girl? She's 12 years. So if she's 12 years, she's below 16 years. So here we are going to take consent from her, that is the girl, and her mother. Okay, so the answer here is C, not from the stepfather. So if it was a father, her biological father, we can take the consent. But those who are less than 16 years old, and if they are have the capacity to give the consent, so they can give the consent, and also, but they require a parental responsibility if they are undergoing a surgical procedure. A stepfather has no legal right to give the consent for the patient. So what is Gillick's competence is, here they check if a patient who is under 16 years old, who are able to understand what the treatment is proposed, and they have the known the risk and benefits of the proposed treatment, and they fully understand that, and they make a wise choice in the best interest, then they can decide. For those who are with parental responsibility, so if the parents of a girl are not or have not married, only the mother automatically can give the consent with the child. An unmarried father, okay, but who is the biological father, has full automatic parental responsibilities for the child. And people with parental authority, so who are or for example who have the legal guardians, so they can also consent for the treatment. Now there is a 15-year-old girl. She is accompanied by her friend who presents to the emergency gynecology unit with crampy, lower abdominal pain and vaginal bleeding. Her observations were stable. Her last menstrual period was 7 weeks ago, and the pregnancy test is positive. So she is pregnant, and what the scan shows missed miscarriage. After discussing the options, she opted for surgical management of miscarriage, and requests you to keep this confidential as her parents are not aware. So what are you going to do here? She is 15 years old. She understands about the procedure and she wants to undergo surgical treatment of miscarriage. So here the answer is you can proceed with the girl's consent as the mother's consent is not necessary according to Gillick's rule. So because she is under 16 years, so she is able to understand what treatment is she receiving, and she is able to make wise choice under her best interest. And in this case, you can proceed with the girl's consent. Now here, a 16-year-old woman is brought to accident and emergency with a history of sexual assault 4 days ago. Okay, the perpetrator had forced her to have vaginal intercourse using condom and also performed digital anal penetration. So you are the doctor in A&E who is now collecting the samples for forensic medical examination. So what all the samples are you going to take, and what is except one which you are not going to take? So in cases of sexual assault, a low vaginal swab, a high vaginal swab is taken, a vulval swab is taken, a perianal swab is taken, but an anal canal swab is not taken in cases of sexual assault. So the answer here is anal canal swab. Now there is a 15-year-old girl who comes to the family planning clinic for contraception, and her period was 6 weeks ago, but the pregnancy test is positive, and she LMP was 6 weeks ago, and she does not want to continue this pregnancy. She wants to terminate the pregnancy. So the following are the basic principles for consenting this young woman for the procedure, except which one? Okay, so except which one is the consent cannot be revoked by the patient at any time before the treatment is given if she retains the capacity to do so. Okay, so if she has given the consent and she understands, then it cannot be revoked, okay, at any time after she has agreed to that procedure, and even if she attains the mental capacity, so the consent cannot be revoked. Now coming to SBA 10, so you are the registrar, senior registrar, and you are going to see a 15-year-old girl in the accident and emergency who is 16 weeks of gestation, and she is brought to theatre for the removal of written products of conception under GA. She is hemodynamically unstable and she is having hemorrhage. Her hemoglobin, she is having severe anemia. It is 5 grams. The patient is scared and her parents decline to give consent for blood transfusion. Why? Because they are Jehovah's Witness. And the daughter wants to have the blood transfusion. Okay. Their parents are not willing to give the consent because of Jehovah's Witness. So what are you going to do? And you're the doctor in this situation. Her hemoglobin is 5 gram. Okay. So here what we need to give is we need to give the blood transfusion to save the girl. The answer is C, because in her best interest we need to do this measure. So in case of life-threatening situation like this, she is already hemorrhaging, her hemoglobin is already 5, and she is 18 years of age. So, and her parents cannot refuse the treatment if which is in the patient's best interest. Okay, so for General Medical Council 0 to 18 years guidance is if the young person refuses treatment, so we should respect the young person's decisions if in making the decision. If they itself refuse, then we can respect the decision. But if the parents are refusing, then we need to act in the best interest of the patient. They cannot override the patient's rights. Now coming to extended matching questions. So here we need to diagnose what can be the most common diagnosis here. So it's a 15-year-old girl who presents with amenorrhea and abdominal pain, and clinical examination reveals a pelvic mass and vaginal inspection demonstrates a pink bulging membrane. So it's a pink bulging membrane and she is with amenorrhea and abdominal pain, which can be due to collection of blood in the vagina, in the uterine cavity, like a hematometrocolpus, and it demonstrates a pink bulging membrane. So what can be the diagnosis here? So there can be confusion between an imperforate hymen or a transverse vaginal septum. But the diagnosis here is H, that is transverse vaginal septum, because here there is a pink bulging membrane. So if it reveals a blue bulging membrane, because it is due to collected blood, dark blood, which is transilluminates to the thin membrane. Okay, so it is due to the imperforate hymen. And What is the differential diagnosis for that? Is a transverse vaginal septum, where the appearance is different. It will be the looking like a pink membrane, pink bulging membrane in case of TVS. Now, what can be the appropriate diagnosis in the following patient? So, she is a 16-year-old girl who presents to GP with intermittent lower abdominal pain and persistent vaginal discharge. And there is no itching or foul smell, but there is pain and vaginal discharge. And she has a history of using IUCD for contraception, and it was inserted a year ago. So, what can be cause of this? So we know if they, especially if they have a history of IUCD, it can be a pelvic actinomycosis. The answer can be G. Okay, which can be associated with abdominal pain or sometimes bleeding, pelvic mass, and it can be treated with antibiotics. But if the symptoms are persistent, in that case, we may need to remove the IUCD. That is the according to the FSRH guidance. So here, what can be the most appropriate management option for this patient? Here, she is already a 15 years old girl who attends the family planning clinic 6 hours after the unprotected sexual intercourse, and she attends after 6 hours after her unprotected sexual intercourse. Her last period was almost 3 weeks ago, that is 21 days ago. So probably she has ovulated if her cycles are regular. And what is the method of contraception they are using is the male condoms. And again, there was a history of condom split, which was around 10 days ago, around the time of ovulation, you can see. Her pregnancy test now is negative. So what is the most appropriate advice for her? So yes, if she is already 21 days, so already the here the most appropriate option would be that we are not going to insert IUCD because there can be a risk of pregnancy which is already there. Okay, so here we can give levonorgestrel 2 tablets, and the pregnancy test can be done if there is no period in 2 weeks time. Okay, so if she misses period, so there is no evidence that the levonorgestrel tablet can cause any harmful effect on the if there is any pregnancy. So that can be given the levonorgestrel tablet, but the chance that it will be successful is very less. Okay, so it can be given only up to 72 hours of the first unprotected sexual intercourse, and it is most effective when it is given before ovulation. So here the failure will be very high, and the chance of pregnancy will also be there. So we will tell the girl to do a pregnancy test if she misses the period in 2 weeks time. So there is a 16-year-old girl who requests emergency contraception. She gives a history of unprotected sexual intercourse which is happened 40 hours ago. So it is within 72 hours. But she's unsure of her last menstrual period. She doesn't know when was her last menstrual period, and we cannot calculate exactly when she has ovulated. So also her cycles are irregular. So her regular contraceptive method is male condom. What is the first step? Okay, always remember the buzzword. What is the first step in management? Okay. So she doesn't remember her last menstrual period. It was how many months back or weeks back. So she doesn't know, and she has unprotected sexual intercourse 40 years ago. So what is your first step? You are going to give her contraception, but when you will make sure that she is not pregnant. So what is the first step in the management is to do a urine pregnancy test. So the option here is option N, that is pregnancy test. Doing a pregnancy test and then making sure she's the pregnancy test is negative. So that is the first step. Okay, so here what is the most appropriate answer? So she is a 16-year-old girl and who attends the family planning walking clinic for a pregnancy test which has come positive. She is unsure of the date of her last menstrual period. She is a smoker and defaulted on her last DMPA injection. She was treated for abdominal pain and discharged per vaginum last week. So what is the most appropriate option here? So she is already with the pregnancy because she had defaulted DMPA injection. So what are we going to do? We are going to do the ultrasound of pelvis to calculate the period of gestation of the pregnancy, or and also to locate the pregnancy whether it is intrauterine or extrauterine. So we know that we give depo provera, that is the DMPA injection that needs to be given the next dose in 13 weeks of time. but they can have extend up to 1 more week. That is, it can be given up to 14 weeks. But if it is more than that, then other methods of contraception needs to be, or an emergency contraception needs to be considered. So here there is failure due to the default. She has defaulted and the pregnancy test is positive. So we need to locate the pregnancy and we need to calculate the gestation. Now here we need to choose the most appropriate answer. So she is 16 years old and is admitted to gynecology ward with abdominal pain, swinging temperature, signs of infection, where there is vaginal discharge and the swab results are not available. Okay, on examination, her temperature is, there is fever, 38.7, and there is diffuse rigidity in the lower abdomen. Her pregnancy test is negative and the ultrasound shows normal adnexa. So what is the appropriate management option? So here the signs are mostly of the pelvic inflammatory disease. So here we are going to, but she is having uh, swinging temperature and all the other signs of infection. So we are going to start her on intravenous cifoxetine and intravenous doxycycline for almost 48 hours when we see for the improvement, and then we follow it by the oral antibiotics. So there is a 16-year-old woman who attends the sexual health clinic with offensive vaginal discharge. The triple swab is taken and the wet mount shows the following motile flagellated protozoa. And what is the most appropriate treatment? So she has come with the gum clinic. There is history of H2I and the organism is a flagellated protozoa, which looks like mostly a Trichomonas vaginalis, which is more seen in age group less than 25 years or who have multiple sexual partners. So the treatment is giving oral metronidazole 2 gram as a stat or 400 mg twice daily for a week. Both are the accepted regimens. Now, what is the best management option for an 18-year-old girl who presents to the OPD with abdominal pain? She has recently relocated to England and has a 6-month-old child delivered by cesarean section. Okay, so examination reveals that she has a type 3 FGM. Okay, so what are you going to do about the 6-month-old child? Okay, so she's a migrant and she herself, the patient, 18 years, has a case of FGM and she has delivered a female baby who is 6 months old. So in that case, you are going to refer to the social services for the benefit of the child, and that should be reported within 1 month. So now coming to next question, it's a 15-year-old girl who is brought to the hospital with complaints of abdominal pain and spotting. Her period was 2 weeks ago and the pregnancy test was negative. Okay, 2 weeks ago her LMP was, she is with pain, spotting. Pregnancy test is negative. She is febrile and no gastrointestinal, and the examination is normal and the pain recovers with simple analgesia. Okay, so looking at the scenario, she is in the mid-cycle when there is mild abdominal pain and spotting. Otherwise, she does not have any signs of infection. Pregnancy test is negative and the pain subsides with simple analgesia, which is suggestive of Mittelschmerz. Okay, that is mid-cycle pelvic pain. Mid-cycle pain which can be seen in mid-cycle time. Okay, and which can be relieved by simple painkillers. Now there is a 15-year-old woman who presents to the hospital with abdominal pain and vomiting. She had nausea for more than 24 hours. So she mostly has gastrointestinal symptoms. She's pyrexial, she has fever and has tenderness with cervical movement. Her urine pregnancy test is negative. So here the options can be, there can be PID. Okay, so there can be, uh, uh, we can rule out ectopic pregnancy because the urine pregnancy test is negative, except although there may be very early where the pregnancy test can be negative, false negative. But most commonly the diagnosis here can be PID or even because there are more GI symptoms, it can be an case of an appendicitis, like there is abdominal pain, vomiting, nausea. Okay, and but there is cervical movement tenderness. So here the most commonly the diagnosis can be acute appendicitis, which is can be seen up to 50% with even with those with PID patients. But cervical movement pain can also be seen in 25% of those patients with PID appendicitis. So that's why to diagnose appendicitis, it is by doing a proper history and doing a proper clinical examination and doing a further investigations and especially imaging the ultrasound to look for the signs of appendicitis. So here the answer is acute appendicitis. So thank you everyone for attending, and I hope this discussion helps you in your exams. Thank you so much.